Καλησπέρα σε όλους και σε όλες. Ελπίζω διαδικτυακή διάλεξή μας, όπου η συγγήτριά μας για σήμερα θα είναι η κυρία Zuzzana Panek, η οποία είναι ψυχολόγος και ο τίτλος της διάλεξής της είναι DSM-5 Classification of Substance Abuse with Emphasis on Drugs. Θα δώσω τώρα το λόγο σε εκείνη. Η διάλεξη της θα είναι στα αγγλικά και κάτω θα υπάρχουν, στο κάτω μέρος της οθόνης θα υπάρχουν και υπότιτλοι επίσης στα αγγλικά για να διευκολυνθεί η παρακολούθηση. Mrs. Zuzzana, thank you for participating in our online lectures. You may start your presentation.
Okay, thank you so much, Isidora. Welcome, everyone. My name is Zuzzana Panek. I'm a counseling psychologist. I actually studied in Greece. I did my master's degree in Greece. And right now I'm working as a counselor with individuals who are content moderators and who are exposed to quite distressing and intense videos. And I provide counseling support for them. Today, we are going to talk about DSM-5 and how DSM-5 classifies substance-related disorders, and we will emphasize drug disorders. Let's start then. Okay, so the agenda for today's lecture will be the following. First, we will start with the definition and understanding of DSM-5. Then we will discuss the benefit of classification systems. Then we will move into talking a bit more about DSM-5 and how it divides mental health disorders. And then we will discuss definition of tolerance, withdrawal, and intoxication. Next, we will discuss separately each diagnosis of substance use disorders. And we will end the lecture by discussing the case study. Okay, so first we will talk about definition and understanding of DSM-5. And what it is actually, what is DSM-5, as it might sound a bit unusual to some of you. So it is a diagnostic and statistical manual of mental disorders, and it is the classification system of mental health diseases developed by American Psychiatric Association. The first edition of DSM was published in 1952, and the latest one, 5th edition, in 2014. And that's the newest edition. DSM-5 is based on research studies, and it applies a theory-based approach. It is one of the most frequently used classification systems worldwide, and it considers psychological, physical, and social factors in its development. And what is the main purpose of DSM-5? The main purpose is easier communication between clinicians, between psychiatrists, psychologists, psychotherapists, the patients, and their family, their relatives, through the use of a common language. Now we will talk about the benefits. Sorry, but I think it's a bit slow. So now we'll talk about more benefits of DSM-5, of the classification systems general. So what DSM-5 provides is the important information of the diagnosis, so of the illness, of the symptoms of the illness, the course of the illness, the prognosis and treatment for both the clinicians, for the professionals, and also for the patients. It provides information for further development of expertise, research, and theories, facilitating statistical records for public health institutions. Also, it has administrative and socio-political causes, as it helps determine patient eligibility for mental health services. So whether someone is eligible to receive treatment from this institution or another one. Also, providing information about diagnosis might be a huge relief for some individuals and also for their families. Moving on, now we will discuss DSM-5 and how it categorizes substance-related disorders. So DSM-5 distinguishes one chapter of substance-related and addictive disorders, which are divided into two groups: substance use disorders, in which individuals are abusing and are addicted to specific substances, drugs or alcohol or tobacco. And there is also a second group, substance and use disorders, where individuals are abusing drugs, and that might cause other mental health disorders. So they might get depression or anxiety or psychosis. And today we will focus mostly on the substance use disorders, where individuals are abusing and are addicted to specific substances. There are 10 separate classes of drugs in the substance-related disorders, and those include alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, as well as stimulants, tobacco, and other unknown substances. And today, what we're going to focus on include illicit drugs, so cannabis, hallucinogens, inhalants, opioids, sedative, hypnotics, and anxiolytics, as well as stimulants. Firstly, we will also talk about diagnostic features of substance use disorders. And the essential features include cognitive, behavioral, and physiological symptoms. All disorders have that in common. That's the essential aspect in having this substance use disorder. Also, another aspect is the fact that the individuals continue using the substance despite significant substance-related problems. So they might be having some impaired functioning, some impaired social, occupational functioning, but despite that, they continue using the substance. Also, by prolonged use of the substances, changes in brain might occur, and that may lead to behavioral consequences of repeated relapses and intense drug craving when individuals are exposed to drug-related stimuli. The diagnosis is based on a pattern, like on a pathological, dysfunctional pattern of behaviors related to the use of the substance. And how can we summarize that? So overall, the diagnostic criteria of DSM-5 can be divided into 4 categories. And that's also how the criteria of the specific diagnosis are explained. So the first category is impaired control. The second one is social impairment. The third one is risky use of the substance. And the fourth one is pharmacological properties. And that includes tolerance and withdrawal. That we will discuss in more details now. So starting with tolerance, it is a condition that occurs when the body gets used to a substance and more dose is needed to achieve a desirable effect, the effect that we had previously, or there is a reduced effect when the usual dose is consumed. The degree to which tolerance develops is different, and it varies across different individuals and across substances. Also, tolerance may be difficult to determine by history alone, and sometimes laboratory tests may be helpful. So, for example, if someone has high blood levels of a specific substance, and that is combined with little evidence of intoxication, that might suggest that there is that there's likely a tolerance to this substance. So now we will talk about just a second. Just a second, because I'm sorry about that, but I couldn't see the next slide. Okay, so now we'll talk about withdrawal. Okay, and withdrawal can be specified as the group of symptoms that occur when individuals discontinue or decrease the intake of the substance. The symptoms of withdrawal depend on the type of the substance. It's different for stimulants, it's different for alcohol or for tobacco. And it also depends on how long it was used. And it varies between individuals. Symptoms of withdrawal can include insomnia, feeling irritated, experiencing mood swings, depression, anxiety, some pains, cravings, fatigue, hallucinations, and nausea. And some even more severe symptoms might include paranoia, confusion, tremors, and disorientation. And symptoms of withdrawal can last for a few days or even up to several weeks. Now we will talk about intoxication. So the essential feature of intoxication is the development of reversible syndrome due to a recent ingestion, due to a recent use of a specific substance. And that is related to decrease or lack of physical and mental control caused by a substance. It might be common among individuals who have substance use disorder, who are addicted and have been diagnosed with this illness, but also it might happen frequently among individuals who are not diagnosed and who are not addicted to specific substance. The most common changes in intoxication involve disturbances of perception, wakefulness, attention, thinking, judgment, psychomotor behavior. So individuals might have it decrease or increase, and interpersonal behavior. And now we'll move to specific diagnosis of substance use disorders. And we will discuss each of them separately. However, it is important to know that they are all very similar. And the description of each disorder is pretty much the same with slight differences. So I might go for the first few for all of them, and for the further ones, I might just talk about some differences. I will explain it to you as we go. So first, we will start with cannabis use disorder. And DSM-5 defines cannabis use disorder as a problematic pattern of cannabis use leading to significant impairment or distress manifested by at least two of the following criteria occurring within a 12-month period. And here are some of the criteria. And the first four criteria are related to impaired control, and criteria from 5 to 7 are related to social impairment. So the first criteria includes the fact that cannabis is often taken in larger amounts or over a longer period than it was intended. There is also a persistent desire or unsuccessful efforts to cut down or control cannabis use. And a great deal of time, so a lot of time, is spent in activities necessary to obtain, use, or recover from the use of cannabis. Also, there is a craving or a strong desire or urge to use cannabis. And now we will discuss the social impairment factors. So cannabis use results in a failure to fulfill major role obligations at work, school, or home. And despite having persistent social or interpersonal problems, cannabis use is continued. Also, important social, occupational, or recreational activities are given up or reduced because of the use of cannabis. Following that, criteria 8 and 9 are related to risk use of the substance. So cannabis is used in situations that are considered physically risky, and it is continued to be used despite knowledge of having persistent physical or psychological problems that are caused by taking cannabis. Criteria 10 and 11 are related to pharmacological properties. So criteria 10 includes tolerance that we discussed previously, and it is defined by one of the following. So either a need for increased amounts of cannabis to achieve a desired effect, or there's a diminished effect with continued use of the same amount of cannabis. The last criteria, so withdrawal, is manifested as one of the following. So either by the withdrawal syndrome for cannabis, which includes being irritated, aggressive, nervous, experiencing anxiety, experiencing problems with sleep, as well as changes in appetite, or cannabis or a closely related substance is taken to relieve or avoid the withdrawal symptoms. And that's the diagnostic criteria for cannabis use disorder. And now we'll move to the next group, which are hallucinogen use disorder. And that includes substances like LSD, ecstasy, MDMA, magic mushrooms, mescaline, and ketamine. And again, DSM-5 defines this as a problematic pattern of hallucinogen use, leading to significant impairment or distress, manifested by two of the following criteria occurring within the last year. And the symptoms here are pretty much the same as in the cannabis use disorder. So again, the substances are used in larger amounts or over a longer period of time than intended. There are unsuccessful efforts to cut down or control the use of hallucinogens, and a great amount of time is spent obtaining, using the substance, and there's a craving and strong desire to use it. Also, there's a failure to fulfill major role obligations at work, school. Individuals might have more absences from work or poor work performance. They might have suspensions or expulsions from school. They might neglect their household responsibilities, their children, their spouses, partners. And they continue using hallucinogens despite those problems. So despite some arguments with spouse or even physical fights. When it comes to risk use of the substance, hallucinogens, when they are used in during driving a car or operating a machine, then it is considered a risky, a dangerous situation, and it is one of the criteria for the disorder. And the individuals continue using the substance despite those consequences. And again, there is an aspect of tolerance. So more amounts of LSD or more amounts of ecstasy or magic mushrooms are needed to achieve the same effect that before. And when it comes to hallucinogens, there is no distinguished criteria for withdrawal. So it ends with tolerance here. And now we will move to inhalants, and that includes glues or spray cans. And again, it is defined as a problematic pattern causing significant impairment or distress within the last year. And the substance is leading to impaired control, to social impairment at work, at home, at school. And the activities that individual could engage in are decreased or given up. So the diagnosis, again, is very similar in description, what it was, how it was with cannabis use disorder and hallucinogen use disorder. There is, again, an aspect of tolerance and how it is defined, that, again, increased amounts are needed to achieve the same effect, or when the same amount of substance, the same amount of inhalants are used, there is a diminished effect of the drug. Now we will talk about opioids. So that includes heroin, morphine, and codeine, which might be found in cough syrup. And DSM-5 defines this as a problematic pattern of opioid use causing significant impairment or distress, manifested by at least two of the following criteria, occurring within 1 year period. And again, there is a case of using larger amount or over a longer period of time that intended, desire or unsuccessful efforts to cut down or control the use of opioids, craving and a strong desire to use them, failure to fulfill responsibilities and obligations at work, at school, and continuing using opioids despite those social and interpersonal problems. Also, the social and recreational activities are given up, and individuals might use the drug in physically dangerous situations. There is also a feature of tolerance and a feature of withdrawal. And when it comes to withdrawal, a specific symptoms, specific syndrome is distinguished for opioid use disorder. And those symptoms might include decreased mood, depression, indifference, nausea, vomiting, muscle pain, enlarged pupils in the eyes, sweating, diarrhea, fever, insomnia. So in this case, the withdrawal symptoms are specified. Now moving to another category. So sedative, hypnotic, or anxiolytic drugs, creating sedative, hypnotic, anxiolytic use disorder. And that might include using benzodiazepines and medication like Xanax or Valium that are used in some mental health disorders, such as anxiety. And DSM-5 is describing it again as the problematic use of those substances causing significant impairment. And again, the substances are used in larger amounts or over a longer period of time. The individuals are not able to cut down the use of the substances. There's social impairment in fulfilling one's responsibilities at work, at school, and individuals are continuing taking the substances despite those problems. There is also an aspect of risk use of the substance when the individuals are using the substances in situations that are physically dangerous and continuing using it despite the consequences, despite physical or psychological problems. Again, tolerance and withdrawal are distinguished. And when it comes to specific withdrawal symptoms, for sedatives, hypnotics, and anxiolytics, so for benzodiazepines, that might include autonomic hyperactivity, being agitated, sweating, having high pulse rate, our heart rate being increased, shaking, having insomnia, having sleeping problems, visual, tactile, or auditory hallucinations or illusions, agitation, psychomotor agitation, so acting with more energy than usual, anxiety, or grand mal seizures. And now we will move to another group of drugs, which includes stimulants. And that include amphetamine type substances like methamphetamine, cocaine, or Ritalin. And again, DSM-5 is distinguishing it as a problematic pattern leading to significant impairment or distress occurring within a 1-year period. And criteria of impaired control, of taking larger amount of stimulants over a longer period of time is done. Again, social interpersonal responsibilities are given up, are not completed, and there is a recurrent stimulant use in situations which are physically dangerous. There is again an aspect of tolerance and withdrawal, and there are specific symptoms related to withdrawal of stimulants, which include fatigue, vivid unpleasant dreams, insomnia or hypersomnia, so sleeping too much, increased appetite, psychomotor retardation, so when we're slowed down, or agitation, when we have more energy, we are more agitated, more energized. And when it comes to all of those disorders, there is also a common aspect of severity. So we can distinguish whether a disorder is mild, moderate, or severe for all of those cases. And when there's a presence of 2 or 3 of the symptoms that we talked about, then the disorder will be classified as a mild. The disorder will be classified as moderate when there's a presence of 4 or 5 symptoms. And a severe case will be when there will be a presence of 6 or more of the symptoms. And now we will discuss a case study. So I will read to you a case study. And I would like you to pay attention to some of the symptoms we discussed and try to list what might be the criteria that are met in this specific case. Just a second, because I cannot see the first line. Just a second. Maybe I will just stop it for a minute. Okay, I will read the first line to you like that, and then I will share the screen again, as I'm not able to see it when I'm sharing the screen. So Mr. M is a 43-year-old legal clerk who has been working in the same office for 20 years. He presents as a referral from his primary care physician to your outpatient psychiatry office for an initial evaluation regarding managing some midlife issues. He states that while he likes his job, it is the only job he has since graduating college, and he finds the work boring, noting that most of his coworkers have gone on to law school or more senior positions in the firm. When asked what factors have prevented him from seeking different career opportunities, he states that he would fail a drug test. Upon further inquiry, Mr. M says he has been smoking 2 or 3 joints or taking a few hits off of his vaping pen of cannabis daily for many years, for which he spent approximately $70 to $100 a week. He first used cannabis in college and initially only smoked a couple hits in social settings. Over time, he has needed more cannabis to take the edge off and has strong cravings to use daily. He reports liking how cannabis decreases his anxiety and helps him fall asleep, although he thinks the cannabis sometimes makes him paranoid, which results in his avoidance of family and friends. Most recently, he identified conflict and regular arguments with his wife over his cannabis use. She feels it prevents him from being present with his family and is a financial burden. He admits missing an important award ceremony for her work and sporting events with his children, for which he had to come up with excuses. But the truth is that he ended up smoking more than he had intended and lost track of time. Mr. M reports multiple previous unsuccessful attempts to reduce his use, and 2 days when he stopped completely, which resulted in terrible dreams, full sleep, sweating, no appetite, anxiety, irritability, and strong cravings for cannabis. Resumption of his cannabis use relieved these symptoms. He denies tobacco or other drug use, including use of synthetic marijuana products such as E2 or spice, and reports having a glass of wine or champagne once or twice a year for special occasions. And now I would like to ask you, what do you think are some of the symptoms Mr. M is presenting? Did anyone notice something? Something meeting the criteria that we discussed previously?
Can you hear me?
Yes, yes.
So if I may say, I would go for irritability, increased levels of anxiety, maybe an inconsistency between family and work related obligations, and chronic use of drugs. Yeah, that's what I'd go for start.
Great, thank you so much. Definitely what you described are the criteria for the diagnosis. So the poor sleep and anxiety, those are the symptoms of withdrawal. So Mr. M is experiencing withdrawal from the cannabis use. He is also not fulfilling his social obligations like Destina mentioned. And he is using cannabis longer and in larger amounts than intended. And he's using it regularly for several years. Anyone else would like to say something? Make any comments? Okay, so let's move on then. So just to remind you, to qualify as having a cannabis use disorder, at least 2 criteria must be met. 2 criteria of all 11 criteria, at least 2 criteria out of 11. And when it comes to Mr. M case, he demonstrates 3 symptoms of impaired control. So from criteria 1 to 4, he is using the substance longer than intended, and he experienced unsuccessful efforts to cut back, and he is also experiencing craving. When it comes to social impairment, he is again experiencing 3 symptoms: failure to fulfill home obligations, persistent problems with his wife, and reduced pursuit of occupational opportunities, as he is having the same job for many years. When it comes to risk use of the substance, Mr. M demonstrates 1 symptom. So he continues using the cannabis despite experiencing paranoia, as he defined it. Also, he is experiencing 2 symptoms of pharmacological properties: tolerance and withdrawal. Withdrawal symptoms including anxiety and sleeping problems. And in total, he meets 9 criteria, which qualify him for a diagnosis of a severe cannabis use disorder. As we said, when there is more than 6 symptoms, 6 criteria met, the diagnosis is severe. And that's the case with Mr. M. And that's the end for the lecture for today. Any questions?